Good morning. Happy Thursday. I'm going to record the review session. I'll go through what to expect for the exams. You have 2 exams next week, one on Monday, one on Tuesday. Your neonatal exam on Monday, we'll review for that one first. So before I get started going through everything, did anybody join me? Yeah, Mary and Gretchen are here.
Good morning.
Good morning.
Good morning.
Do you have anything specific you'd like to discuss?
Not that I can think of. I'm sure as we start reviewing, I'll have questions, but not off the top of my head.
Okay, sounds good. All right, so for neonatal, the PowerPoints, make sure you go through them front to back. Let me close my door. Hold on a second. Okay. For neonatal, make sure you review all the PowerPoints up until when we stopped. And let me go through them as we speak. Actually, I want to start with something that I don't think I made clear enough during class. So I want to start there and then we'll begin at the beginning and go through everything. And it's talking about when a newborn arrives, what do you do if the heart rate is greater than 100, less than 100, less than 60? Because there are some scenarios on the test and it'll give you a description. And pretty much you go by what the heart rate is as far as what you do respiratory wise. Yes, it's true. They're not breathing. You start bagging. Yes, it's true if I lost my train of thought. Their O2 sats are low. You want to provide extra oxygen. But pretty much you go by heart rate and what to do. So that's how I want to break this down. So a heart rate 120 to 140 at birth is considered good. That's a normal heart rate. So just observe. Nothing needs to be done respiratory wise. And as a matter of fact, any heart rate greater than 100 per minute, all you do is observe the infant. If it says something like O2 sat is low, you want to give some positive pressure and increase the FiO2. All right, let's see if it made sense. So heart rate greater than 100 per minute is considered acceptable. So unless it gives you any other clues that you might need to give oxygen, then having a heart rate greater than 100, you don't have to do anything. But if it says after 1 minute, the saturation is 50%, that's lower than the expected. So after 1 minute, you would expect O2 saturation to be about 65%. So if you're not achieving 65%, now you want to give some oxygen. And how should you give that oxygen? So you'll hold a mask over the newborn's face and deliver some positive pressure. So it's called mask CPAP. And I'll show you the NEO-T. We start the neonatal airway on Monday, and then you'll be rotating through. So I can show you how to deliver some positive pressure to the newborn. And then if O2 sats are still not where they need to be, you just keep increasing your FiO2 to get the sats to come up. All right, so heart rate greater than 100, good. Heart rate greater than 100, but low O2 sat, you want to give some mask CPAP. All right, heart rate 60 to 100 per minute. Positive pressure ventilation. So any heart rate 99, heart rate 70, that's considered low. And instead of waiting for it to come up, because typically once oxygenation improves, then the heart rate starts increasing. But if the heart rate is that low, between 60 and 100, you want to start bagging with positive pressure ventilation. Did I give you the amount of pressure to use when you're bagging an infant? I don't know if that was part of the notes. No, it doesn't look like I gave you the criteria for bagging. Okay. So PIP, 25 centimeters of water. Keep, 5 centimeters of water. And you bag 40 to 60 times per minute. So figure like around every second you're squeezing the bag. All right, so if you're going to do positive pressure ventilation, because the heart rate is low, it's less than 100, it's somewhere between 60 and 100, you're going to start bagging the infant, and that's what you're going to use. Pressure 25, PIP 5. You're going to squeeze the bag 40 to 60 times a minute with short eye time. All right, and then the last one is heart rate less than 60 per minute. Move it up. If the heart rate is less than 60 per minute, that's the clue that you need to be doing compressions. So not only do you want to start bagging, so positive pressure ventilation, but the newborn will also need chest compressions. So heart rate less than 60, it's a full-blown code. Compressions, ventilations, and then intubate the infant. Or we shouldn't call them infant. intubate the neonate. So if you can remember the 3 different categories for heart rate, so greater than 100, 60 to 100, and then less than 60. Those are the 3 categories. And then what should you do? So better than 100, you don't have to do anything unless their O2 stat is low. 60 to 100, you want to start ventilating, so positive pressure ventilation. And heart rate less than 60, not only are you doing positive pressure ventilation, but you start compressions. So if you can remember that and add in when you would use some mask CPAP. So anytime O2 stats are not the acceptable level per minute, then you want to deliver oxygen via mask CPAP. And I think that's good. So I wasn't sure that was described well when I was giving you lectures. So I wanted to go through that first.
Professor, do we need to know the FiO2 percentages for the different times of minute post-birth?
Yes. So the first, if you can remember the first minute and what it should be by minute 5, instead of having to memorize every single minute, that'll be good enough. So when they're born, you want to, the first minute, you want to see 60 to 65% O2 stat. And then by minute 5, it should be up to 85%. I don't have it memorized either. Yeah, so after 5 minutes, 80% up to 95%. So if you can remember those 2 numbers, that'll be good. All right, so I'm just looking through the PowerPoint and I'll just call out topics that you need to review that are going to be on the test. So beginning with the first PowerPoint, the fetal to neonatal transition, you have to know when to call a neonate, or when you call them an infant, when you call them pediatric, etc. For the placenta, you have to know where it normally implants in the uterus, what it's called if it implants other than normal. So what can happen to the placenta that compromises the fetus. You need to know that chorionic villi are the names given to the blood vessels from the fetus. They grow into the placenta, and that's how it gets its oxygen and nutrients from the mom. So chorionic villi. You need to know that the umbilical cord has 2 arteries and 1 vein. The arteries leaving the fetus and going to the placenta actually has the deoxygenated blood. So that's the low amount of oxygen going from the fetus to the placenta to pick up oxygen. And then after the blood is oxygenated, it comes back via the fetal vein. And that's what goes into the inferior vena cava and then up to the right heart. You need to know that fetal hemoglobin has a higher saturation at a specific percentage. Another way to say that, if we look at it on the oxygen dissociation curve, we see that the curve looks like it has shifted to the left. For the different stages of lung development in utero, you need to know the name. So embryonic, pseudoglandular. That third stage, canalicular or canals, is when you're getting most of the growth of the pulmonary vessels and the capillaries, as well as the sinus of the lung. So it begins to mature by the end of that stage. So canalicular stage is 17 to 26 weeks. So by the 26th week, the distance between the alveolus and the capillary is getting smaller. So it's easier for oxygen to get from the alveolus into the capillary. And if the baby's born prematurely, at the end of the canalicular stage, it's possible for their lungs to support life. We may have to have them, we'll be giving them surfactant most likely. We'll have them on positive pressure to help improve oxygenation, have them on increased FiO2s, but it is possible to sustain life. And the youngest newborn is now, that survives, is between 22 and 24 weeks of life. Do they have a lot of developmental issues because they're born so prematurely? Yes. During the canalicular stage, that 17 to 26 weeks, there is surfactant being made in the type 2 cells, but the surfactant isn't mature enough yet. So that's why typically when the babies are born that prematurely, we end up having to give them some exogenous surfactant. Moms are given steroids. So if it looks like labor and delivery are going to happen, then they will give the mom steroids at least 24 to 48 hours before delivering. And if you give it to mom, the steroid makes it through into the fetus and it develops the surfactant. So they're born with their surfactant being mature. And we know that full term, a baby born after 38 to 40 weeks of gestation is considered a full term neonate. Less than 38 weeks, or I can't use that number again. So less than 37 weeks, it's considered premature. So the fetus is surrounded by a sterile fluid, and that's called the amniotic fluid. And the amniotic fluid is, it's not like a stagnant fluid. It gets absorbed by the uterine lining and then resecreted. I think I gave you statistics of how often it's absorbed and resecreted. When they do a fetal assessment to see how the fetus is doing in utero, they'll use an ultrasound. The name of the testing is called the biophysical profile. They'll look for the amount of amniotic fluid, and having too much amniotic fluid can cause brain damage. Apparently it's putting too much pressure on the developing brain. And not having enough amniotic fluid also puts the neonate at risk. I didn't have a description. I just know that it's called, not a description. Oligohydramnios is too little amniotic fluid. Yes, it does affect fetal development, but I didn't give you details as to how. So it's normal for the fetus to be moving in utero. It's normal for the heart rate to be going up and down, but seeing no fetal movement, the heart rate is not changing, that indicates fetal distress. And a C-section may have to be done because the fetus is not doing well. The tests that are performed when a sample of amniotic fluid is taken, there's some testing that can be done on the amniotic fluid. One of them is to determine the gender of the fetus, to do genetic testing, to look for trisomy 21, spina bifida, cystic fibrosis, things like that. They can also use the amniotic fluid to determine how developed the surfactant is. So the fluid that's surrounding the fetus is also inside the lungs. So that fluid moves out in and out of the conducting airways, and it'll contain components of surfactant. So by running some testing on the amniotic fluid, they can determine how developed the surfactant is. So we went through the different testing. One of them was the LS ratio. That's comparing the amount of lecithin to the amount of sphingomyelin. And if there's twice as much lecithin than sphingomyelin, then the surfactant is mature.
Can you repeat that really quick? I mixed up the two words, so I wasn't sure which one.
Okay, I can type it also.
Thank you. It's a big word.
So with the LS ratio, or lecithin to sphingomyelin ratio, twice as much lecithin than sphingomyelin means the surfactant is mature. The most accurate testing looking for surfactant is when they look for that phospholipid called phosphatidylglycerol. TYDLE? Tidy L-glycerol. There we go. Just its presence indicates surfactant maturity. Its presence indicates surfactant maturity. It's shows up about the 36th week of gestation.
And what was the name of that test?
The whole word, phosphatidylglycerol.
okay.
So the first test before that you're talking about is the one that has to be above 2?
Yes.
Okay.
Yeah, so that's why I wrote twice as much. So the ratio has to be 2 to 1.
Got it.
And then the lamellar body count might be something you come across when you're looking through the medical record of the neonate you're taking care of. But it's not on the exam. I just noticed it discussed in Oak's pocket guide for neonatal information, and it mentions the lamellar body count greater than 50,000. So after you graduate, I know your big focus is taking the 2 national exams, your therapist multiple choice exam, your simulation exam. You need to be registered in order to start working. So you want to get those out of the way. But if you have an interest in working in neonates and pediatrics, there's another exam you can take, and you could turn around and take it like right after you're registered if you so desire. To get your neonatal pediatric specialty credential, that test may ask you about the lamellar body count. That's why I want to throw it in there, even though I don't have it on my exam. Okay, then we went into fetal heart rate. The heart is developed into 4 chambers by 8 weeks of life. So using vaginal ultrasound, a heartbeat can be heard. Then we talked about fetal heart rate during labor and how contractions can affect the fetal heart rate. So what happens when the uterus contracts is it will squeeze the fetus. Sometimes it squeezes the placenta. So just squeezing the fetus, there will be a fall in the heart rate. I guess it causes like a bradycardia when it squeezes the head, like a vagal stimulation, heart rate goes down. That's not a problem. That doesn't compromise the fetus in any way. But if when the uterus contracts and it's cutting off the blood flow in the placenta, that's a problem because now it's stopping the blood flow from getting to the fetus. And how can we tell if the placenta is being squeezed or constricted and blood flow is being compromised? By looking at fetal heart rate. And if we see the heart rate decrease after the contraction, then we know that it's compromising the fetus. So a heart rate late in decelerations, I think is how it's worded. Let me see. If heart rate decreases late in the contraction, that indicates uteroplacental compression. So that means every time there's a contraction, it's compromising oxygen delivery to the fetus. So they probably want to do a C-section right about then. And then we talked about the 2 belts around mom. One is looking at the contraction, one is looking at fetal heart rate. Okay, and then we went into maternal history. So you need to know the different problems with mom that can put the fetus at risk. Being diabetic will cause a very large for gestation newborn. Hypertension can develop during pregnancy, and it's called preeclampsia. There's also protein in the urine. Preeclampsia can also lead to seizures during pregnancy, and if seizures occur, it's called eclampsia. Mother's age makes a difference. So being less than 16 years of age, greater than 35 years of age causes high risk pregnancies and high-risk deliveries. Cigarette smoking constricts the placental blood vessels, or constricts mom's blood vessels and the flow going to the fetus. So when mom smokes, the fetus is not getting as much blood supply and they will be born smaller than normal. Drug dependency for mom. Drugs do pass through the placenta into the fetus. It can cause withdrawal symptoms in a newborn. Cocaine is a potent vasoconstrictor, so it greatly reduces blood flow to the fetus. And they usually end up mom usually ends up going into labor really premature. The babies are hard to manage after they're born because they're very irritable, they're withdrawing from the drugs, plus they're born prematurely. So they have a lot of issues. Alcohol causes low birth weight newborns. They can be born mentally retarded. They can have neurodevelopmental delay. And then there's some certain facial features that can occur with facial deformities that can occur when moms are consuming alcohol during pregnancy. I have listed cleft lip and palate, but I think we looked it up during lecture. As far as, I think the forehead's a different size. There was a couple other things, small upper lip. All right, and then we talked about during delivery, what can compromise oxygen delivery to the fetus. So in order for the fetus to be born, they have to go through the cervix, and the cervix has to dilate to 10 centimeters for the head to fit through. It's real painful for mom. If narcotics are given, the narcotics relieve the pain for mom, but the narcotics also go through to the fetus, and the fetus can be born with respiratory depression. So you notice that their respirations are very weak when they're born. That might be the heart rate of less than 100, and then you have to start bagging. And we talked about how to reverse the narcotic by giving Narcan to the infant, to the newborn. The drug that speeds up labor is called Pitocin, or oxytocin is the generic name. So suppression of labor, or what tocolytics can be given to suppress labor from occurring, because you want the fetus to stay in utero as long as possible, as long as they're getting oxygen and nutrients. You want them to stay in utero as long as possible to develop in mom as long as possible. So they may need to stop labor from occurring because it's too soon for labor to be occurring. And magnesium sulfate was one that'll relax the uterine smooth muscle, as well as beta-2 agonists being given intravenously or orally. And albuterol, I don't know if albuterol is good orally as it is when we give it inhaled. But I know terbutaline is another beta-2 agonist that they have pills for it, or they give it IV to mom. Suppressing labor, tocolysis. Then we went into gravida para. Talked about the gravida is pregnancies, para is births. Sometimes there's one number for each, and sometimes the para number is broken down into full term, premature, abortions or miscarriages, and then babies born living. So I gave you examples. Did you guys feel comfortable with that, or? Does that need any further explanation?
I'm good on it. I'm not sure about.
Yeah, I'm good on that.
Okay. All right, and then we went into fetal transition. So you need to understand the blood flow while the fetus is in utero and how it's different from adult circulation. So with the lungs not providing any oxygen, and we talked about, yes, if you look at ultrasound, you can see the fetus has breathing-like movements. And that is developing their muscles for breathing, but there's no gas exchange taking place in the lungs. The only gas exchange that occurs in the fetus is through the placenta. So when the blood returns from the placenta, goes to the inferior vena cava, that's going to have the most oxygenated blood. And then that blood flows up into the right atrium. Of course, the blood in the inferior vena cava typically goes through the liver to be metabolized, but there's a shunt in place with fetal circulation, and the liver is bypassed. So that blood goes directly into the right atrium. And then the different pathways, once blood is in the right atrium, there's two pathways the blood can take. One pathway is crossing over from the right atrium over to the left atrium, because the blood has already been oxygenated. So it can go through from the right atrium to the left atrium. It passes through an open flap, and that flap is called the foramen valve, and the blood flows into the left atrium. Once the blood is in the left atrium, it does its normal pathway just like it does in adults, where it goes left atrium, left ventricle, and into the aorta. Then the second pathway, blood flows into the right ventricle. When the heart contracts, blood is flowing into the pulmonary artery. So the blood that flows into the pulmonary artery, about 10% of it only will flow to the lungs. That 10% will help the developing structures. It'll give them enough oxygen for the developing of the lung. The rest of it will take the pathway of least resistance, which is through the ductus arteriosus. So that's a wide open vessel between the pulmonary artery and the aorta. And the ductus arteriosus will carry blood from the pulmonary artery and deliver it directly to the aorta. So those are the two pathways for fetal circulation. Okay, and then to transition from fetal circulation to adult circulation, what has to happen? And at birth, when the baby's first born and they're still getting their blood flow from the placenta and they're getting oxygenated, they don't have a drive to breathe. So typically when the umbilical cord is clamped, now they're not getting their blood flow from the placenta. Now, as the blood is flowing down the aorta, it's going to meet a resistance. So instead of flowing to the placenta, that's plugged up. And it causes the pressure in the aorta to increase. It also causes pressure in the left heart to increase. And when you have higher pressure on the left compared to the right, it causes that foraminal valve flap to close. Other things that happen is with the acidosis and the low amount of oxygen occurring in the newborn, that's going to be a strong stimulus to take a deep breath. And when they take a deep breath, that opens up their airways and alveoli, and now you've got oxygen coming into the alveoli. That causes the pulmonary vessels to relax, and now you've got the blood, all of the blood flowing to the lungs to pick up oxygen. So that's the transition that happens at birth. Okay, when baby is delivered, their head is delivered first. And that's normal, and that's what is needed in order to come through the birth canal. If their feet come first, then their head could get stuck. So a breech delivery, they typically would do a C-section and surgically take the baby instead of allowing them to be delivered and get their head stuck. Okay, babies are born, you have to keep them warm. They lose a lot of body heat. So they're placed in a radiant warmer. Their towels, warm towels are used to dry off the wet skin because wet skin loses body heat. Okay, once the baby's born, we want to monitor the heart rate. And the best way to do that is to put EKG leads on their chest. We want to monitor oxygen saturation. Best thing to do is put the pulse ox on their right hand. The right hand is going to receive the highest amount of oxygen. And we talk about that a lot more when we go into neonatal diseases. Okay, and that's when we got into, all right, you hook up the neonate, you dry them off, keep them warm. You're monitoring their heart rate, and you see their heart rate is 120 per minute. Okay, that's good. Look at their breathing. Okay, that's good. Then you just observe. So as long as their heart rate is above 100 per minute and they're not having any problems or any respiratory distress, then you just observe. However, if you see that their oxygen saturation is lower than expected, so we said 60% during the first minute, 85% by 5 minutes. No, I have the hardest time memorizing things. 80% by 5 minutes, then you need to give them additional oxygen, and you will do that with positive pressure, so mask CPAP. If the heart rate is between 60 and 100, that's your clue that you want to start positive pressure ventilation. You're going to ventilate 40 to 60 times a minute. Don't use any pressure higher than 25 centimeters of water and a PEEP of 5. Heart rate less than 60. Yes, you need to be bagging, but you also need to be doing compressions. Get the newborn intubated. They'll probably start a line in their umbilical cord and give epinephrine. And I think that's as far as we got. So I'm going to have to address some of the test questions because we stopped there. Is there anything that I went through too quick and you have questions about it? Okay. You also have an exam coming up for advanced equipment. So and then I have a list of things that's on that exam. And again, it's all of the PowerPoints, so make sure you review your PowerPoints. And then let me type in my list. So first thing I have is to categorize all modes. Do you remember what that means to categorize a mode of ventilation? You mentioned what cycles inspiration. You mentioned whether it's like volume cycle or pressure cycle. No, I didn't want to say that. Volume cycle or time cycle, flow cycle. And then you also want to mention what's limited, whether it's volume or pressure. And PRVC is something where you mention 3 different things. So how do we categorize PRVC? All right, goodbye, Taylor. For example, categorize PRVC. So you would mention it's pressure limited. And then it's cycled by time. So when we set an inspiratory time, when that time is up, inspiration ends. And then the third thing we have to mention with PRVC is that it's volume targeted. So the pressure is going to vary to target a tidal volume. The other example I want to give you, because it seems like students miss this one the most, and that's describing pressure support. All right, with pressure support breaths, it's something that we add to a patient's spontaneous breath. And it's pressure limited. So in pressure support, we set the amount of pressure support. But the way that a pressure support breath ends is when the flow going into the lungs slows down. The ventilator knows that the patient is finishing up their inspiration. So flow cycle, so flow diminishing or flow cycle, it's called, is what ends inspiration with pressure support. There's one more that I'd like to go through with you because it's another one that gets missed, and that's volume support. So in volume support, it is a pressure support breath. However, the pressure support level will vary from breath to target a tidal volume. So if 10 of pressure support is not enough to give a 400 ml tidal volume, then the ventilator will increase the amount of pressure support on the next breath. So just like PRVC, you're going to see your pressures fluctuating from one breath to the next, not during a breath, but from one breath to the next to target a tidal volume. So pressure limited part stays the same. It's flow cycled. When flow slows down, inspiration ends. And then we also have to say that it's volume targeted. So everything else, you guys usually do really well with it, but I just wanted to review these 3 to make sure you have them. All right, so I know I'm skipping my notes, skip around. So as you're going through your PowerPoints, my list is not going to match up very well. But I want to mention types of asynchrony. So types of ventilator asynchrony. So we talked about several different ways that the ventilator is not in sync with how the patient is breathing. One of them was how our sensitivity is set. If it's not set sensitive enough or it's set too sensitive. If we see double triggering, where a breath goes in and then there's no exhalation and then another breath goes in, that's the patient breathing in and trying to get more tidal volume than what was delivered to them. Of course, it could also be a big leak somewhere, but assuming no leak and you see one breath after another and no exhalation, the patient is trying to get a bigger breath of air than what we have set on the ventilator. And we talked about ways to fix that. So if the ventilator is set in pressure control, just giving a longer inspiratory time will allow the patient to take in a bigger breath. PRVC, it may help to increase the inspiratory time. But once you have, in PRVC, you have a targeted tidal volume. And if the volume goes in and the patient still wants more, they're still going to double trigger, even if you're increasing their inspiratory time. So increased inspiratory time helps with pressure control. And then also in volume control, we set a flow rate. Sometimes that flow rate that we set is not enough to satisfy the patient's needs. They're trying to breathe in fast, and then the air is flowing in really slow, and they're going to feel this air hunger, and they're going to be sucking in, trying to get the air a little bit quicker. So if you see like flow starvation or how do I say pressure doesn't build well during inspiration? I think I described it as a scoop.
Yeah, like you could say the waveform is not decelerating flow. Am
No,
I
we're looking
thinking
at
the right thing?
pressure.
So if
Oh,
you're
I see
talking
your
about
point.
the flow is like just slow. So like if you changed it to decelerating, wouldn't it be like really fast in the beginning and then slow?
Yes.
Am I understanding that right? And that would
Yes, you are.
help? Okay, thank you.
All right, so if the flow is not enough in a volume mode, so I wrote change to decelerating flow waveform. That's going to help. Also increase the peak flow rate setting. So if you start off on 40 liters a minute or even 50 liters a minute, sometimes that's not enough flow for them during inspiration. So you might have to go to 60 liters per minute. Then you have some test questions on ventilator changes with bivent or APRV. So in bivent, when you have time at high pressure, that's your inspiration. Time at low pressure is your exhalation. So this mode creates a huge inverse ratio ventilation. And it has that inverse ratio on purpose because we know if we trap air, it's like having, it is auto PEEP and it does improve oxygenation. So here's an instance where instead of trying to avoid air trapping and auto PEEP, we actually want air trapping and auto PEEP because it will improve oxygenation. So we recommend this mode for patients that have severe hypoxemia with conventional modes. If they're on an FiO2 greater than 60%, they're on PEEP greater than 10, and their saturation is still less than 90%, then you could recommend this mode of ventilation. And all right, so that time at high, if you have a long period of time at high, it's great because that pressure will pop open the alveoli. But a long inspiration and a short exhalation, there isn't much time to get rid of CO2. And CO2 might start to build up. So what can you do to get rid of CO2 on okay, one thing I didn't write down is what are the 4 settings for bivent? Let me move this down a little bit. P high, pressure high, I guess, and P low. All right, doesn't want to fit anywhere. So you have to know how long to keep the pressure at high and what the pressure at high should be. And then how long for time at low and what the pressure should be at low. The pressure low is typically set at 0. Because of the air trapping, the pressure never gets down to 0. So changing it doesn't really make a difference. So the first one I wrote, to change the CO2, you decrease the time at high, and that will cause more frequent exhalations, and you can get rid of CO2 that way. So to change the CO2, change the CO2. How about if I put if the CO2 is high. Okay, so those are the three things you can do to improve the CO2 level if it's high. So you get a blood gas, CO2s are high, what can you do? So if you decrease the time at high, you're going to have more frequent exhalations. It's kind of like increasing the respiratory rate to blow off CO2. So same thing. And then again, more pressure, bigger tidal volume, that's going to blow off CO2. If you give more pressure support on the spontaneous breaths, the spontaneous tidal volume will be bigger. That's going to blow off CO2. All right, now what about for oxygenation? What if we get the blood gas and we're not oxygenating well? What would improve oxygenation? The obvious one would be increased FiO2, right? Or if you trap more air, that improves oxygenation. So how do you trap more air? How about decrease the time at low pressure? So if you decrease the time at low pressure, you're going to trap more air and oxygenation is going to improve. Okay. So there's questions on volume support. But again, I was telling you, make sure you go through all your modes. If patients in pressure support, how do you know how much, I didn't say that right. If the patient is in volume support, how do you know how much pressure support is being used for their tidal volume to be achieved? And the answer is look at your PIP or your delta P actually. So if you have a PIP of 25 and a PEEP of 5, your delta P is 20 centimeters of water, and that's how much pressure support is needed to achieve the volume in volume support. So there's a couple test questions on that. For auto mode, remember auto mode is just the switch back and forth between full support and spontaneous. The patient stays in full support until they initiate 1 or 2 breaths. That'll switch the ventilator over to spontaneous mode. So it was PRVC and volume support. It was pressure control and pressure support. So those are the 2 that we'll end up seeing at the hospitals. So there's a trigger timeout, kind of like an apnea. So if the patient's breathing spontaneously and then they stop breathing, I think it's between 7 and 12 seconds, then the ventilator will switch over to full support, but you don't hear an alarm. It just switches back and forth all the time. There's no alarm. How are you supposed to know if the patient's been in full support the whole time or have Did you just happen to walk in when they're not breathing? And you would go to the trends and look at the trends for respiratory rate, and that would tell you. What else with auto mode? Trigger timeout. Yeah, I think that was everything you need to know for auto mode. And then there's a couple scenarios where you have to look at a blood gas and say what ventilator settings you would recommend. You have to calculate ideal body weight, and you have to calculate mLs per kilogram. So if a 60 kilogram ideal body weight patient is receiving a 700 ml tidal volume, how many mLs per kilogram are they being ventilated with? So here I gave you the ideal body weight, but if I were to give you the height, you have to know how to convert their height into their ideal body weight. So here, all you have to do is take the tidal volume, 700 ml, divide by their ideal body weight, 60 kilograms, and that'll give you the mLs per kilogram. Do you guys have a calculator?
I got 11.6.
Okay. So they're being ventilated with 11.6 mLs per kilogram. And what would you recommend? So if they have normal lung parenchyma, they're not an ARDS, what tidal volume would you recommend for this patient?
I would say that's too high. We want to do 5 to 7, correct?
6 to 8.
Oh, 6 to 8, sorry.
Yeah.
Professor, can you give us an example of one of the questions where you said, like, we'd have to look at a blood gas and then say what kind of vent setting?
Okay, sure.
Thank you.
So we're shooting for 6 to 8 mLs per kilogram. Got to tell you about this. 6 to 8 mLs per kilogram, and they're 60 kilograms. So that's what, 360 ml would be a good tidal volume. Up to 480 ml would be a good tidal volume. So that's what we would recommend. So we don't get volume trauma. And then for driving pressure, I should have had it on my list for you. To keep driving pressure so driving pressure is plateau minus PEEP. And I'm going to give you a blood gas in a second. I'm afraid if I don't tell you this now, I'm going to forget. So the driving pressure is the plateau pressure minus PEEP. So we're not looking at pressure, just trying to push the tidal volume through the conducting airways. We want to take that part out of the picture and just look at the pressure that reaches the alveoli. So that's our plateau pressure. Plateau pressure minus PEEP. They're calling this the driving pressure, and you see this a lot in the literature when you're reading. Keeping that 12 to 15 centimeters of water will prevent lung injury. So you would turn down the tidal volume until you get this driving pressure to be between 12 and 15 centimeters of water. So if you started off with a 700 ml tidal volume and your driving pressure is really big, you go down to 600 ml, do another plateau. It's still too big. Keep turning your tidal volume down until your driving pressure is between 12 and 15. And then you're safely ventilating the patient. So that goes even further than our just looking at tidal volume. All right, so now for ABG changes with vent settings. Let's see. We can assume a normal bicarbonate. So we have a patient in PRVC mode. The rate is 10 breaths per minute. The tidal volume 300 ml, FiO2 0.6, and the PEEP is 5. I guess we're going to assume the patient's not breathing. So their total respiratory rate, 10 breaths per minute. And we get a blood gas, and what do we see? So anytime you look at a blood gas, you always start with the pH, and the pH is acidotic. All right, so to fix acidosis, we could blow off more CO2, because the more CO2 we have in our blood, the more acid in our blood. So if we get rid of extra CO2, that's going to put our pH back in range. So how can we blow off CO2?
Can increase the respiratory rate.
Very good.
Okay, so you just mean like what changes to make with the current vent setting, whatever you, I thought you were asking like we'd have to determine what vent setting to actually use. But you mean just what changes to make on the current like vent that it's on the current mode, I'm sorry. So we don't have to figure out the mode, just what settings to adjust.
No, there is a bonus question that asks you to select a mode of ventilation and ventilator settings for a COVID-19 patient. And in that case, you want to come up with everything. So tidal volume, you're going to mention your driving pressure, rate. I give you a rate of like 12 to 20 per minute. No, 20 per minute, I'm sorry. FiO2, PEEP. So you're going to want to recommend all those things. Let me write that down. Let me move it up a little bit. Oh, after I click out of it, I can't move it up. Oh, man. All right, so I rewrote it up at the top. Select a mode and vent settings for a COVID-19 vent patient. Vent patient. I went way over with my 1 hour review. I have one more thing to tell you. So this is a test question also. If the peak pressure is 40 centimeters water and the plateau pressure is 15 centimeters of water, so that's a huge difference between those two numbers. What could cause the big difference? Do you guys know the answer? No? So the reason there's such a big difference between those two numbers is that there's a lot of airway resistance. So it could be the patient's biting on the endotracheal tube. Maybe they're intubated with a really small endotube. Maybe there was a lot of swelling. They had to use an unusually small size endotube. That's going to create a lot of airway resistance. Bronchospasm can create a lot of airway resistance. So you have a lot of airway resistance that's going to cause pressure to build up, but that pressure is not being felt in the alveoli. That's just in the conducting airways. So when you stop the flow of air and you do a inspiratory hold or a plateau pressure, you're only looking at the pressure in the alveoli. And if that pressure is low, but peak pressure is high, you know you have a lot of airway resistance. And turbulent flow, I mentioned, if you have a short inspiratory time, it causes high peak pressures. So if you set the I time for an adult, like at a half of a second, and you're trying to push all their air into their lungs in a half of a second, you're going to get high pressure. And then when you do a plateau, you'll see it's a lot lower. So that would be another one to add to our list. Turbulent flow from a fast inspiration is going to cause a big difference between the two. All right, that's all I've got. That's a lot, right?
Thank you.
Thank you so much.
You're welcome. Bye now.